I'm Gretchen Kuda-Crowan, Senior Editor for Practical Cardiology, and you're listening to an interview with Dr. Mariell Jessup, Chief Science and Medical Officer for the American Heart Association. Dr. Jessup and I spoke about the cardiovascular risks of hydroxychloroquine and azithromycin, as well as the risks posed to medical students and trainees on the front lines of the COVID crisis, the changing roles of telemedicine, and more. Stay tuned. So with me today is Dr. Mariell Jessup, who is the Chief Science and Medical Officer at the American Heart Association. Welcome, Dr. Jessup. Thank you so much for your time.
Thank you. It's my pleasure. I hope everybody is safe and healthy in your house.
So far, so good.
Great.
Okay, so one of the things I wanted to talk with you about today is the question of using the anti-malarial drug hydroxychloroquine and the antibiotic azithromycin. That's gotten a lot of hullabaloo in the press lately. There's been a big question about whether we know enough about those drugs to safely use them and whether or not they're effective. But my understanding is that people with cardiovascular disease may be in a very unique position. So I'm wondering if you can just talk to me a little bit about what are the specific concerns that we have about using those two specific drugs in patients with COVID-19 and heart disease.
Sure. So we have known for a long time that certain drugs have the potential of increasing what we call the QT interval. Those are components of the ECG. And by doing that, we're changing the refractoriness of the heart's electrical system. And some patients who may or may not already have a somewhat prolonged QT interval, and some people that have damaged hearts for a variety of reasons, and some people who have genetic abnormalities that influence their QT interval may, in fact, with some drugs, prolong that QT interval even further, setting up a potentially lethal ventricular arrhythmia or irregular heart rhythm. And it even has a very fancy name called torsade de pointes. Which is a French name, and most physicians know about it because the rhythms that you see on an ECG or a rhythm strip is particularly telltale.
Yeah, recognizable?
Yes, very recognizable. So there are a group of drugs. There's some antibiotics. There are some drugs, interestingly enough, that are given to patients to quiet down arrhythmias. But azithromycin has a pretty small potential, but a known potential. Hydroxychloroquine has a known potential. If hydroxychloroquine was given to lots and lots of people, it's pretty uncommon to see a marked development of torsade de pointes. But the combination of two drugs, both of which have a small potential, given together will increase that risk. We felt that it was important to bring this up, and cardiologists might not necessarily put it together that hydroxychloroquine and azithromycin added together may have an increased effect on QT prolongation. But the combination, as you said, has been touted to be beneficial in COVID-19 illness.
So today, then, the American Heart Association, along with the American College of Cardiology and the Heart Rhythm Society, published some guidelines then about what they think is appropriate for the use of these drugs and where they should or maybe shouldn't be used in patients with cardiac disease. Can you give me sort of a rundown of what those guidelines say?
Right. Well, we didn't say where they should be used or not to be used. We said, if you're going to use these,
if
you're going to use these, make sure that you get an ECG, or some people say EKG, beforehand, and make a note of their QT interval. And if there's any reason to think that that patient may be susceptible to QT prolongation, make sure that you monitor this patient carefully. So in somebody that has underlying heart disease or maybe on other drugs that have an effect on QT interval, it certainly isn't something we'd advocate that you send them home on hydroxychloroquine and azithromycin.
Right.
And I think we wanted to raise the level of sort of being aware of this complication. And as always, drugs have to be balanced out, their potential for good and their potential for adverse effects. Right now, the potential for good of this combination is not well established. So it's all the more important, we felt, that this drug combination not be used without careful thought and consideration of the underlying patient and their condition.
So for patients who are maybe currently receiving this therapy, or they have already received it, because no one thought of it at the time,
right.
Is there any ongoing research? Are people trying to compile some of these case studies to get a really, a better understanding of when there are adverse reactions, and what to be on the lookout for, as you said,
right.
to get a better understanding of the outcomes of patients who have had this.
Right. So these reports originally came out of China, and then a world-renowned cardiologist named Dr. Silvia Priori from Italy has begun and she is a longtime volunteer of the American Heart Association and the European Society of Cardiology, has already started in Italy a registry of patients that go on the combination and whether they develop any of the torsades de pointes. So she's maintaining that registry in Italy. But the question you ask is an important one, and that for that reason and many other reasons, the AHA announced this week that we are going to have a registry of patients with COVID-19 illness that get admitted to the hospital. And we're on the lookout particularly for cardiovascular effects, complications of cardiovascular disease and stroke. And I think we'll learn more about how often, if those patients are taking the drugs, how often complications of torsades de pointes actually develops.
Are you encouraging patients themselves to, be educated about the fact, if they have heart disease, to sort of be educated about this and know that, if they do come down with symptoms, that when they are admitted, if they are admitted to the hospital, and this is suggested that they take these drugs, that they maybe, raise at least the question of whether this is the right course of treatment for them, rather than just blindly accepting, hey, my doctor knows what's best.
I'm hoping that physicians will, again, as we said, weigh the potential benefit of these unproven combination drug in COVID-19 versus the potential adverse events. The American Heart Association has spent a long time educating patients as well as clinicians, but in our public-facing announcements, trying to educate them about their diseases, whatever their cardiovascular disease is or stroke, and educating them about the role of their drugs and the role of potential things that can happen as a consequence of their underlying cardiovascular disease. So I would hope after both our efforts and individual clinicians, including nurses and doctors, describing to patients with serious heart disease, that they'll be aware of the potential effect of arrhythmias, irrespective of what drugs they're taking. But I also hope that they'll question their doctors when they're prescribing these medicines, say, what's the evidence that this drug combination will work? What's the potential side effects? I guess what we've been concerned about is that people have a way of getting these drugs on their own.
Oh,
And lots of people have azithromycin around that they may have been given for an upper respiratory infection. And lots of people are getting hydroxychloroquine from, well, we don't know where they're getting it all, but there's lots of medicine. So we're just afraid that patients are taking this combination on their own, and that's a big concern too.
yeah. I think it's generally a bad idea to try to treat yourself with medications that you don't understand, especially combinations of medications.
Exactly. It's
Generally
exactly right.
Yeah, I mean, and I wasn't suggesting by any means that,
No, I know.
people should contradict their physicians, just that they elevate the conversation a little bit to make sure that these are things that are getting addressed.
Right. And recognize that there's all kinds of physicians that are treating these patients. Many people may be pulmonary doctors, they may be internists, they may be family physicians. It's not just cardiologists that are treating these patients. In fact, it's unlikely that they're being seen by cardiologists unless they have an underlying cardiac disorder. So it's not necessarily true that this whole range of physicians understand about the potential for developing lethal arrhythmias with this drug combination. So that was part of our reasoning in issuing this alert. And there's been several other really good articles in other journals talking about this potential drug combination as well.
Right. I mean, long QT syndrome has been the kind of thing that people pay attention to with lots of different types of drugs, as you mentioned.
Right.
So, I think most pharmaceutical companies are regularly testing for that to make sure that
Exactly
there
right.
doesn't initiate a kind of cardiac arrhythmia. Is this something that obviously, as time wears on, we may find other drugs and other treatments that could potentially be useful in treating COVID-19? So, I mean, it sounds like this might be the sort of thing that we're going to have to pay attention to with any type of treatment that might be up and coming as the months and years, hopefully not
Right.
we're on with this.
No, you're absolutely right. I think anytime there's a new drug, among all the things that pharmaceutical companies have to test for, the potential for prolonging QT is one that they routinely look for in drugs that behave in certain mechanisms. I mean, you can predict which drugs may or may not do this. So as new drugs come on board, they'll certainly have to be tested for that. What everybody's hoping, of course, is that a vaccine will come sooner rather than later, and hopefully that will be a more definitive answer.
Right. Hopefully. We are all crossing our fingers for that one.
We sure are.
Let's pivot the discussion really quickly, because one of the things that you mentioned was, you may not be necessarily treated by a cardiologist. You probably won't be. You may be treated by any number of types of doctors in the emergency room and whoever is available at the time, depending on the severity of the outbreak where you are and when you end up being admitted to the hospital. And one type of doctor that you might be treated for is someone who's relatively new to the profession. You could end up with a trainee who hasn't, fully completed their fellowship yet, or residency, or even a recent medical school graduate. So this raises a whole other level of concern here. I know that this is another issue that you're passionate about, and that is whether or not that is a good idea for the patients, and also maybe for the doctors themselves, their own protection. And so I'm wondering if you can sort of talk a little bit about what the concerns are about early graduation for some of these students and pushing them out into the field, into what is really a very big deal and a lot of risk involved too soon.
Right. I think it's worth repeating many times that one of the great miracles of this pandemic is watching healthcare workers in general step up and put themselves in harm's way. And most everybody from nurses and therapists and psychotherapists and doctors, it's all, what can I do? How can I help? And that's so wonderful and can't be acknowledged enough. The problem with trainees still being on the front line is first and foremost that we've heard over and over and over again, a lot of these healthcare workers don't have enough personal protection equipment or PPE. They're being asked to share, to use one mask all day long. They may not be getting the right body cover. And that's a travesty in whomever is being asked to be on the front lines. But the fact that we're putting the next generation of healthcare workers, the next generation of doctors, we're hurrying them along. They may not even know the specifics about what PPE they need. And we're asking them to go do things that they may not be fully trained for, that therefore it may take them longer to do and may not have the proper supervision. Then that added to the fact that they're not being protected is wrong.
Yeah.
Of course they want to help, but it's wrong to send them out there unprotected on the assumption that young people don't get sick and die, because we're hearing that that's not true.
Right. Right. I mean, and is that the assumption, like that people were making, that, hey, they're young, they're like, you know,
invulnerable? Yes.
Vulnerable. Yeah.
Right. I think it's acknowledging that schools, classes, normal training circumstances have disappeared. I mean, the formal rounds have been hugely modified in most teaching hospitals, and nobody can concentrate on anything other than what is happening in the hospitals.
So I'm sure they feel like we need to be in there doing medicine.
Exactly. And that's the point, that they went into medicine for a reason, and here is a once a century medical emergency. Of course they want to be there. But they're young and they're vulnerable, and it's our job to make sure that they're protected and that we're putting them in situations that they can handle at that level of training.
Right. Is there an argument to be made, like you said, that, regardless if everybody has the same amount of PPE, that simply the fact of their lesser amount of experience, that they are more at risk than a more experienced and, experienced physician?
Right. Well, one of the ways that physicians learn is sort of an apprenticeship. And so typically they'll see their attending physician do a study, and then the next time they'll do the study, like a procedure, with their attending physician watching over them. And that's the way physicians learn. They learn by being part of a group. They learn by seeing lots and lots of patients supervised by an attending physician. Suddenly, if they're out in a situation where they haven't been and there may not be an attending physician there, then they're not prepared. And that can sometimes happen. That happens in war, and this is a war, that people that are ill-prepared to do things still get thrown out there. We understand that. But most places in this country, that kind of level of wartime situation is not there yet. And it's inexcusable if they're not protected.
So what is the right way to let them help? How should they be helping? And how should they be supervised?
Well, there's lots of things that I have heard about that people are asking their medical students and interns. There's all kinds of registries going on to try and make sense of this, to learn from this experience, because this virus will be with us. So that's one thing, is they can stay out of harm's way. The second thing they can do is start calling patients at home. They can help with the telehealth that has become the norm now, which is very time consuming and emotionally very difficult. Most physicians I've talked to that are doing telehealth, they'll all say, I know I need to do this, but it's really hard and it's emotionally very wearing. So I think young doctors can do that and can be another ear. They can also do a lot of paperwork and taking down histories, and there's a lot of paperwork that has to be done out of harm's way, but they know enough medicine that they can just make sure that everything is getting properly documented. So there are lots and lots of things that young physicians can do, especially in a setting where there's not enough PPE.
Right. So it may not be the most exciting thing that they want to be into, but it really is important job and like very useful.
Very, very useful. And I think what we're recognizing, as in any huge emergency like this, it's the unsung heroes, and it's every step of the way. Everything has to be working well for there to be success. And I think that's, we all been seeing on social media, the team of clinicians that stand around when a patient who's been desperately ill and on a ventilator is at last going home. You can't really tell the expressions on the patient, and you can't tell the expressions on the team because they all have masks on, but they're all there, and each one of those members is rejoicing, and they were all required to get that patient home.
Yeah. You mentioned that like it's emotionally really difficult to do this telehealth, and I just want to ask you a little bit more about that, because is it that they're having to see patients who are sick and it's like they don't really have that physical connection to them, or is it that they're isolated from their colleagues, and like what makes it so hard?
Well, what I think I'm hearing from a lot of people is that it's difficult. That, I mean, part of being a physician is human contact, and although you can talk to someone, or you might even see them on Skype or Zoom, but there's something about the physical touch, feeling the patient's skin and their pulse and being able to examine them, which you can't do by telehealth. And that's profoundly disturbing to clinicians, that they're used to having that human and healing touch. Also, it ends up being a very sort of open-ended visit. So people, first of all, like all of us, we don't see other people, and we don't get to talk to too many people. So patients want to talk, and they're frightened, especially if they have severe cardiovascular disease. I mean, they want to talk to their doctor. And so the visits take a long time. The doctor comes away feeling like they don't completely know how well the patient's doing. And it's a huge different experience than what we've been trained to do and what we've done most of our lives. So it's, anything new is jarring.
It's really interesting that you say this. And one of the reasons why I find that comment interesting was that I spoke with a doctor from Mayo Clinic just last week, and he's in, his focus is preventative cardiology.
Mm-hmm.
And from his perspective, he says patients love it, right?
Right.
And I'm wondering if the difference is healthy patients and wellness like related televisits really work so much better than when patients are very sick or scared, and that it changes the dynamic completely depending on what you're trying to accomplish.
I think you're so right. I think that context is critically important. That probably if you're there for prevention, you're really happy not to have to schlep into the office.
Right, I know.
You know, like, hey, this is great. You know, where do I get my blood taken? And then why do I have to see anybody anyway? So I think we're going to learn a lot from the patients that really could do telehealth really effectively, and the patients where it's going to be really important that they get seen by a human being. And I am optimistic that that is one thing that will come out of this experience, that everybody's been pushing the boundaries of telehealth for quite some time. And this is an opportunity for us to learn which patients need to be seen and which patients don't. So I think you're exactly right that the patient that doesn't have complex disease is probably very happy to be not having to go to the office. The patients that have real medical problems, on the other hand, or think of the patients that have cancer,
Yeah.
and how they're getting their chemotherapy. Think of the patients that, I'm a heart failure transplant cardiologist. I'm talking to my colleagues who have patients who are on ventricular assist devices. Think about that they're home frightened and afraid to go to the hospital, but they have a very complex device in them.
Yeah.
So I think it does vary by disease category.
Although, like you said, I think one of the benefits that may come out of all of this is that we were forced into it. And by being forced into it, it's sort of forced the healthcare system to adapt, right? I know there were issues with billing and getting, reimbursed for these calls and televisits.
Right.
But the system has now had to say, okay, we've got to accept this now. We sort of treated, I think, for a while as the redheaded stepchild, of we're not really going to treat this as real medicine or as really valid, doctor-patient interaction. And I think maybe now we're finally seeing that it actually is valid. It may have its limitations and it may have more and less appropriate contexts, but it is actually useful in situations like this and perhaps other situations that we haven't envisioned yet.
Yeah, I completely agree. I think we have to look at it as an opportunity that because nobody likes change, but this is a change, as you say, that was forced on us. So we'll have to take advantage of it.
Yeah. Okay. Well, thank you so much for your time. That was a really fascinating conversation, and I really enjoyed talking to you. So,
well, I really enjoyed talking to you too. Thank you, and please be safe. I saw a little head peek in the door the other while ago.
I had already warned my kids. I'm like, no, stay out. Mommy's on the phone.
I know. I have a dog that does the same thing. So, all right. Thank you so much. Take care.
All right. Bye.
Bye-bye.
Thanks for watching. I hope you enjoyed this video. For more cardiology news, please check out our website, practicalcardiology.com.